and I'm very much looking forward to it. So with that, Dr. Baker.
Okay, thanks, Andrew. And thanks to all of you for inviting me. I'm a general pediatrician. I worked a lot with kids with autism and general pediatrics, and I complained enough that my department chair made me director of the autism clinic for a couple of years. So I became kind of a fake neurologist for a while. So I have a special place in my heart for neurologists, actually, and I've worked a lot with you. So it's really an honor to be here. I'm going to, let's see, share screen. Okay, sorry, I didn't get I thought they were going to appear. Bear with me for 1 second. We had okay. Here we are, good neurology grand rounds. Okay, got it. Sorry, I didn't thought this was.
Click the slides.
Yeah, I've done this.
Share.
Okay.
Oh, yeah, make it full screen.
Yeah, I'm make it full screen.
No, I take that back.
I share first, right?
Yeah.
Where's the share?
So click on Suma.
Okay. Done this a million times. Let's see. There we are.
Yeah, share.
Okay, share screen. Okay,
Here
we go. Good.
And then screen.
Yeah, let me just get slideshow right. Yeah.
And then hide the floating meeting control.
What's that one I hiding?
Click more. And then hide floating meeting. So.
This is the first time I've ever given a Zoom presentation. No, sorry, I just didn't. I thought it was going to be a little more setup. Okay. Well, anyway, I'm a historian too, and I've worked in a lot of different areas, but the last few years, I guess for fairly obvious reasons, it seemed that racism was a really important thing to think about. My take on that has been that it's really important to understand how racism is played out in medicine, not just in general or abstract terms, but how what's happening in our own backyard. I believe local history is really important, and especially for you who are training here, I really just want to encourage you to, whether you end up here or somewhere else, to learn the history of your community and your own institution. So we're going to explore some of that today. Here we go, sorry. Okay. And I've actually been working in this area for several years, so it's not going to be everything that I've worked on. I've done Vast Connections projects. I've done a big project with Don Taylor called Mission, Money, and Duke, the construction of Duke's medical enterprise. I'm going to pick some stories out of this that I hope will illustrate some of the bigger points. We're going to try to understand the history of how racism is played out at Duke through 5 specific stories. I hope this will illustrate to you how structural racism is operated over time in ways that often the people of the time weren't even conscious of what was happening. Understand how the histories we're going to talk about are often forgotten at Duke, but are remembered in the community. So that's some of the big themes. And my first narrative, I'm just called the origin story. The story of how we get started is always, stories of how a place gets started are important, right? Because they tell us how we pick that story tells us a lot about us. So here's one narrative you'll hear in the community about how Duke got started. People in Durham have long referred to, not people of color in Durham especially, have referred to Duke as the plantation. And I've seen quotes in the Indy saying that Duke was created by plantation owners and it's still a plantation today. This may be for Richard. So I want to kind of explore, first of all, that phrase speaks volumes about the experience of some people at Duke and to the hierarchy they experience here. What is the history behind that? So Duke does go back to the Duke family, right? To Washington Duke, who you can visit his homestead today. Washington Duke was actually typical. He did not run a plantation. He was typical of many small farmers in North Carolina. He was white. Census records indicate that he did own one enslaved woman named Carolyn. So there weren't hundreds of people like at Stagville. I don't want to imply that was benign by saying only one and not huge numbers. In some ways, in that setting, you can imagine Carolyn had far less privacy, far less companionship among our own. But that is the situation Washington Duke grew up in. We probably would never have heard of Washington Duke had it not been for the fact that after the Civil War, he came to Durham, and this is the time when when the tobacco industry rose. And Washington Duke came to town with his sons and set up a tobacco factory to compete against the Bull Durham brand. And his great dream was to become, well, really his son's dream, James B. Duke, was to become the biggest tobacco man in the country. And he had a big battle with the leader of the Bull Durham brand. And he eventually won it by automating cigarettes. And it was a huge breakthrough that put him ahead. A breakthrough, we could read in different ways there, right? But a breakthrough that made the Dukes a lot of money. And by the 1890s, James B. Duke had in fact acquired virtually every other tobacco company in the country, 80% of the country's tobacco wealth, making him sort of the equivalent of Andrew Carnegie or John Rockefeller, but in tobacco. This brought the Duke family enormous wealth. And although they eventually diversified to energy, that's why you pay your bills to Duke Power today, and to textiles, that's how the money began. And this is a picture of American tobacco that you've all seen as well. I want to emphasize that the Dukes are not the only elite in Durham. Durham was known around the country as having one of the most successful Black middle classes in the country. You might have, I didn't realize you had a talk last week about that, but you probably heard something about that. It was in Durham that the North Carolina Mutual was set up, the largest, probably in the early 1900s, the largest Black-owned company in the world. And the leaders of that were just known around the country, praised by Black leaders such as W.B. Du Bois. And of that group, I think one point I guess I want to make it, I skipped over, is that the Dukes and the Black leadership will actually work together politically. I don't want to imply they were cozy friends, but the Dukes were industrialists. The Republicans in the North were the party of industry, the party of Lincoln. The party of Lincoln was also the party of African Americans. So they would actually often cooperate politically against the Democrats, who were actually the party of white supremacy in the South in this time period. So it's an interesting political alliance that's going to be a theme here. Lincoln Hospital was founded by one of those founders of the NC Mutual, Dr. Aaron Moore, and it became probably one of the best known African-American hospitals in the country. Although it was very much Moore's idea to develop a Black hospital, he cooperated again with the Duke family for some of the money, although it is very much shared with the leadership of the NC Mutual. So that's an interesting story we could talk more about later. But I'm going to focus more on Duke today. So in late in years, those sons of the Duke family, James B. Duke and his brother Benjamin, found the Duke Endowment. The Duke Endowment is actually kind of interesting. It was an endowment created to support education and healthcare. It supported explicitly healthcare for both races in the South. In fact, it is the only Southern-based philanthropy that supported healthcare for African Americans as well as whites. That's unusual. And that may go back to that earlier political relationship that I've talked about. It was not just a philanthropy, but it very systematically tried to work with hospitals, both Black and white, provide money, and it provided financial support for care of people of both races, including Lincoln Hospital and a future biracial teaching hospital that would be in Durham. And one of the very first things the Duke Endowment did was actually to basically match the contributions of the Black business community to basically rebuild and expand Lincoln Hospital in 1924. One of the very first actions of the endowment. And it's really at this point that Lincoln becomes so well known around the country. Many future Black leaders will be trained here. That medical school will happen, of course, at Duke, and they recruit a dean from Hopkins, and the idea was to bring a bunch of Hopkins doctors down here to what they thought of as the global South. I mean, there were diseases in North Carolina like hookworm, pellagra, tuberculosis, and it was kind of an adventure for these Northerners came to the South. Thankfully, air conditioning was invented about the same time. Davison's vision was to mainly train primary care doctors in the 1930s. He would actually discourage people from going into research. Things have changed. Anyway, So that's interesting how things worked out in these first years. His vision was, again, following Duke endowment, for a hospital to take care of both races. But in line with how things were run in this time, the vision was to have a hospital that had both races, but on separate wards. And this is actually one of Dean Davison's diagrams from 1927. And you can, I don't really have a pointer, but the top right, sort of the north, the 2 o'clock picture is the entrance into the Davison building, what we now call. Yeah, good. Okay, can you see the mouse? Okay. So if you're coming in from West Campus, Cameron Stadium is that way, and coming here, this is the entrance into the Davison building. This is where all the really powerful people are today. And these first 3 quads are the old hospital. And you will notice, although the medical schools in this first building, the teaching areas, one of the things that strikes out, will strike anybody looking at this is this floor, white men's surgical beds, colored men's surgical and medical beds. So there is clearly segregation, and the Duke endowment kind of went along with Southern assumptions about how that would happen. So our great question is, how is this going to play out over time? But when you see that diagram, you just think, oh, this is just so awful that people would have done this. But at this moment in time, I kind of want to emphasize this is actually a little better than the standards of the time to even envision a hospital that has both races. Things are actually going to get worse rather than better at Duke. And why that happens has to do with a story of some bad things that happened early on that weren't expected. So I'm going to call this second story a story of crisis and transformation. So Duke Hospital finally opens in 1930. It is about the worst time to open a hospital as you can imagine, because this is the low point of the Great Depression. And very quickly, the hospital is overwhelmed by non-paying patients. They were called charity patients. Remember, there is no insurance in this time period. There's no Medicare, there's no Medicaid. And the hospital is just struggling. It almost closed. 80% of the patients in the early years were considered charity. And most of them came from over 20 miles away. So they're not even from Durham, they're coming from a large catchment area, from a big area. And Davison's first big struggle is just to keep the thing afloat, to keep it from closing down. And he tries a lot of different solutions, including, by the way, an early Blue Cross statewide plan. And we can talk more about that later on. But in the end, he's going to have to, he's going to try different solutions and sort of making it up as he goes. One of the first things they did was to create an outpatient clinic, because people were coming in just to be admitted. They needed a way to screen folks. So this outpatient clinic opened in the 30s. The first one was based in the basement of that old green zone. You can still kind of go through the space today. It was set up as a clinic. I kind of wanted you to think about, so like, where are the, how does this break down ethnically? This waiting room looks pretty white. And what we find is we can actually see advertisements for the hospital. It would say, if you're white, you can come in, we're open at 8. People of color, they didn't use that word, Negro patients could come in at 10 or 11 o'clock in the morning. So this must have been a picture taken about 8 o'clock in the morning. One of the very few pictures we have from this time period. That's medicine, which is in the basement. I have no separate pictures for neurology, by the way. This is the pediatric clinic. And this is on the first floor. You can still find this space in the yellow zone. And this picture looks pretty different, right? This is, I think, the Well Baby Clinic. And it's clearly all African Americans. My department likes to talk about itself like we never had any segregation in our department. But I'm not sure that was true, because here's the same hallway on a different day of the week. And it looks pretty different. So they must have had some sorting hat mechanism with the phone triage that people were just going along with. So this is kind of how things were flying. And so as you look at these pictures, you sort of ask yourself, so I'm sure the doctors here were saying that we're treating people equally, but were they? Let's sort of think of that question as we look at these. Yes, sir. He is, but there's some other very important people. I guess I'm skipping right over Daryl Hart, head of surgery, who's going to develop the PDC, which I'm about to talk about, which will become a very independent, important force. Yeah, That's right, but heart will become very important with that. Yeah, it's a complex story, and so I'm trying to paint it in big strokes. So to survive financially with all these patients without insurance coming in, they try lots of solutions. They often, but a big part of the strategy, it becomes bringing in private patients as well. And it's not just a crass, let's get rich kind of thing. It's really, they really are just trying to keep from closing. They weren't able to pay the doctors or give them vacations or anything. Well, that's the origins of the private diagnostic clinic, which at first is a survival mechanism. It will become very successful as the depression ends and start actually bringing in revenue. And that revenue will actually enable the hospital to be expanded. So I think you can better see in this next image I'll show you, which is the hospital in the additions in the 1940s and 50s. So again, here's those first pictures I showed you are this section here, the old hospital. Again, here's Duke's West Campus. In 1940, this big expansion was added. It was called the PDC building, and all the bed, it included not only clinics, but also more beds. The beds were all private or semi-private beds. And then in the 50s, another addition is added, again, adding further private and semi-private beds. So you're starting to see what I'm saying about how things are not actually getting better. It's kind of more of a story. It's not a story of things starting bad and then steady progress. We like those stories, right, in medicine. So it's more of a story of, I think, a moment of some interesting potential to go either way, I think, with you kind of look at the dreams of the intent of the Duke Endowment. But then it starts to evolve in a direction of more and more move toward the private patients. And I want to show you some more pictures from this period as we go to the 40s and 50s. We have more images from this time period. So here's in that new building. This is a picture of the new outpatient clinic. And this is an interesting image to think about. So you see a lot of African Americans out here. And then there's this line of white people who are coming ahead, clearly ahead of the other group of the African Americans. And I think what we're seeing here is, again, that system where basically whites come in, you know, at 8 o'clock, and African Americans don't come in till later. By this point, I think it's more like noon. And again, sort of think about how that would have played out. Think about your clinics at 4:30 in the afternoon, which is always in my clinic, at least the witching hour, where things are just really, that's when most complicated people coming in. So now kind of think about how, if you were a person of color, you would have been in that group. And we do have letters and stories of people who had, say, diabetes, who just were coming in so late, they were sent home again, and then they came back with complications. So not the very most dramatic disparity that it might have been. I mean, it could have been totally separate areas, but still significant disparities. I think the more striking disparity than this is the comparison between this clinic, which is still the outpatient clinic. These are people who have very few resources, versus the private clinic I mentioned. And this is, what happened to the picture? Sorry about that. Looks like the picture got zapped. Anyway, sorry about that. I had a nice image of this other clinic, which is for private patients. And you see like one gentleman with a dress like me reading a newspaper, and two other people in the waiting room, and they're all white. And it looks like a very easy experience where you can just read a newspaper and see one doctor. I'm so sorry that picture got taken out of here. So that's a big discrepancy. It's sort of being built into the system some. And it's sort of like the revenue from the private patients is enabling the hospital to survive, the Duke Medical School to survive. It is offsetting the care for the outpatients. We have far fewer pictures of the inpatients, and this is one from psychiatry. Psychiatry had no service. It was actually called neuropsychiatry in the 40s. But I think it was what we would call psychiatry. This is an image of the Myers ward, which is actually built in the older section of the hospital, the 3rd floor. I'm not sure what's happening to this person. It's some kind of immersion therapy. These volunteers are conscientious objectors who are serving for free because in exchange for not having to go to the Second World War. They're white, obviously. So psychiatry opens in the 40s. It has no Black patients at all. It is a purely white service. So you can still go to, and I take students around through Duke Hospital, and you can go to, we've done so much renovation, it's hard to see traces of how things used to be. But if you go into the yellow zone, take the elevator 2 floors up. I think you can see traces of how these office areas were once wards. That is actually not ward, NOTT, which was an African-American ward. And there's a parallel hallway to it just down the hall that was the white ward. It's just interesting to look there and try to imagine how things must have looked in those days. I don't have pictures of what it would have looked like. I will say Knott ward, I might just mention, NOTT, is named after Josiah Knott, who was one of the notorious medical racists of the 19th century. I can say more about that later on. I think, and I've interviewed people who are medical students and residents back in the late 50s, early 60s, and they will say, yeah, I remember the wards were separate, but we provided equal care, okay? And they feel very confident about that. And I think it is the question raised by this, where was that happening? And I want to try to address that question through one story. And it's a story that I've actually really been working on a lot with a colleague, Damon Tweedy, and the story of a man named Malthus Avery. Raise your hand if you've heard this story. Thank you. I had to hear it before. One of my goals is that everyone at Duke someday recognize this name and know who this person is. I think it's really important. Now, there's a background to this story, which is another person who is more famous. This is Dr. Charles Drew. Can you raise your hand if you've heard of Dr. Drew? So more of a recognizable name. Dr. Drew, I think arguably was the most famous African-American surgeon, if not physician, in the United States in the mid-20th century. He's remembered as a great innovator in blood banking. Showed that if you separated the plasma, you could store it from the red cells, you could store it a lot longer. Such a breakthrough that he, as an African-American, was made director of the American Red Cross's blood banking service in the Second World War at a time when black and white blood was still segregated. Drew resigned over that, by the way, but it's quite a testimony to how prominent he was. So what does he have to do with North Carolina? He never actually practiced here. Drew went up to Howard University and taught there after the war. His connection with North Carolina was that he died near here. And after the war, he would travel from Howard to the Tuskegee Institute's medical school at Tuskegee Institute to give lectures. And in the course of one of those overnight drives, he's driving overnight because you can't stay in hotels in North Carolina. And after that driving all night, his car, he fell asleep at the wheel with his residents. As he was driving a group of residents, he fell asleep at the wheel in Alamance County, very close to Burlington. Car spun off the road. He was taken to Alamance General Hospital in Burlington and died there. And very quickly, around the country, the story spread that he died because this white hospital had refused to give him blood. I don't know if any of you ever heard that story. It's a very, very widely told story that I heard growing up. It's a powerful story, right? Because this man who's the pioneer of blood transfusion is not given blood in his moment of need because of segregation. It's a powerful story. I want to say it's not true because it captures the truth, but it's not factually accurate. Drew, in fact, as far as we know, was treated. And probably the best testimony of that is that there were black doctors with him who accompanied him to the hospital. They said that the hospital did try to treat him. His injuries were just so severe that there was no time to even order blood. So why did this story emerge? I mean, part of it is I just think it would be a totally believable story. It would have been turned away. I don't think you need to find more than that. But there's actually another story that merged into this story. And it's a story of this man who you haven't heard of, Malthus Avery. Malthus Avery was not a famous person. He was an African-American soldier in the Second World War who, after the war, in Henderson, North Carolina, after the war, he was going back to school in NC-A&T College. And at the end of his first semester, he was doing well. At the end of that first semester, he was driving back from Greensboro back to Henderson. If you know North Carolina, that would take him right through Alamance County. And he was in an accident as well that was within a few miles of where Drew's accident had been. This happened in December as opposed to April. He was taken to the same hospital that Drew was taken. Alamance General, and they assessed him. They realized that he had likely had a epidural hematoma or some intracranial bleed. Now that wasn't racism to transfer him on, because they had no neurosurgeons, so they knew he needed a transfer, and UNC hospital didn't really exist at this point, so that meant transfer to Duke, and he was sent to Duke's emergency room. This is the night of Friday night, December 1st, 1950. We know that he was assessed for about 10 minutes in the emergency room, and a resident said he wasn't a candidate for surgery. 10-minute assessment, and there were no beds to observe him on the Black ward. So he was transferred to Lincoln Hospital. And as he arrived at Lincoln Hospital, he coded, and he died in the emergency room on his own. His family learns about it from the police. They come down, and they are just enraged when they hear this story. They let the papers know. And this story, forgotten today largely due, was headlines in the time. This is the story, the front page of the Carolina Times, Durham's Black paper, reporting what happened. It's reported by Black papers around the country. Black papers are an important network of knowledge in this time period. And President Hollis Eden's mailbox fills up with letters you can still read today of people saying, what happened? And I'm doing a lot to work on telling the story in more detail. It's a horrible story. It has been argued, and it's actually, I think, been shown pretty well, that over time, Avery's story is gradually forgotten over the course of the years, but it merges together in popular memory with the Drew story. I could talk more about how that happened if you're interested, but it's a really interesting example to me about how people, how kind of memory works, and you can remember something that may be about Drew, who's a well-known figure, but it didn't happen to him, but yet it does capture truth that happened to many, many people, okay? And I find this a really, really powerful story on that level. A story about memory. It's also a story about structural racism, because as far as we can reconstruct, and Dr. Tweedy and I have worked a lot on this, it's not so much, we don't think that they were just like blatant racists in the Duke emergency room and said, we're just not going to touch this person. It's, there weren't beds on the floor. And why weren't there enough beds, Black beds on the floor? Well, because Duke didn't have enough beds for Black people, although it did have those separate wards. And Duke had about 16% of its beds were for Black people. That compares to about 30% in the community, whether you talk Durham or the surrounding area. So you only had a half of the beds you needed. That's the structural issue that seemed like people just kind of went along with. And that meant that it was actually pretty routine when a Black person came in with an emergency to Duke, and Duke didn't have beds, they would be sent to Lincoln. And that often didn't go well. Remember, he was sent to Lincoln. The Lincoln doctors weren't even called in advance. We have documentation of that. And I think this is a comment by the director of surgery at this time, Dr. Charles Watts. He said, Avery was typical of a lot of patients sent on to Lincoln under the guise of no beds. Every afternoon, we would get 4 to 5 patients whose object was to go to Duke outpatient clinic. 4 to 5 patients. Many were sent here who should not have been. Proper medical care would have dictated that you do not move a patient to a smaller, less well-equipped hospital except that they were Black. This is structural racism and inaction. And the thing is, just like Duke doctors just assumed this is just how things are. They just went with it. It was sort of framed as, I'm sure, I'd like to think some of them experienced moral distress on the front line, but were there discussions, oh, we need to expand the number of beds? I didn't see any explicit discussions. So the story is important, I think, on 2 levels, both the level of the thing about memory, how the story has been remembered. By the way, even Avery's, I shouldn't imply that Avery's story has been totally forgotten. We have found African-American pastors in the community who remember, members of their congregation, older members, who remember Avery's story too. But I guess what I say, but his story probably was forgotten more outside of the Durham community, and the Drew story kind of took it, fused into it. So working a lot more on the story. Actually, Dr. Tweedy and I are working on a podcast with primary, so we can involve the real voices from the story in this, including I've met Malcolm Avery's daughter, who's going to participate in this. The daughter was born a week after he was killed. Okay, so let's kind of get from there to now, and I wanted to really make that the focal point of this presentation. Obviously, that's a horrible story. I can still imagine people reacting to that and saying, "Well, that was the '50s, Jim Crow era." Well, surely things have changed since then. So let's talk a little bit about what's changed and what's not changed. I'm going to really compress the story of desegregation at Duke. It happens remarkably fast. Like in some, the legal situation changes very fast, thanks to a lawsuit and then basically edicts coming from Washington. Hospitals around the country desegregate very quickly from 1960 to 1965, or I should say legal segregation ends quite quickly. But what happens is, I was tripping over my words there a little bit. What happens is that it's not, I shouldn't say that segregation ended. Legal segregation ended, because what happens, in fact, is a slow process by which de facto segregation continues to happen. This old order of black and white wards gives way to a new order that are called public and private wards. Okay, with the public wards managed by residents, the private wards managed much more by attendings. Over time, those public and private open wards gradually get subdivided further. They turn into private rooms. So that kind of aspect of structural racism goes away. But the clinics continue to be a space that you continue to see, again, de facto segregation. It's called public versus private, but you see some of these some of the public clinics, they're in different spaces, and they tend to have far more African Americans than white patients. That's a really important point. That continued to persist. It's a little hard to say how far, well into the end of the 20th century, and we can argue about beyond. Why do you get these de facto kind of segregation? Sometimes it is because of individual, what we might call prejudice, and we do have stories of white specialists who just wouldn't see black patients. Those stories are out there. I think the bigger issue is this sort of the payer status issues, that this old system of using private patients to offset the quote losses from public patients really also drives sort of a need to attract private patients, offer them perks and the like. And that's a really huge issue as well. And on top of that, I think there's just the whole issue of teaching clinics and those private patients. And there's more white patients get insurance early on for a variety of reasons that favors white patients. They're probably more likely to push back against as much involvement of residents. I'm making very sweeping comments here, but I think this dynamic might be a fair way to characterize a very complicated dynamic where people who are on Medicaid, which for a long time doesn't provide nearly as much as private insurance, they're sort of reserved for the trainees quite a bit. And that leads to a lot of unequal treatment. I've done a lot of we've done a lot of oral history work. I'm just going to pick two quotes because of time. This is from a Duke resident in the late 60s, and said there were different clinics in the hospital for black patients and white patients. The black patients were rarely seen by the attendings, just by the residents. They were kind of considered learning material. And the black wards were all multiple bed open wards. That word learning material is really a trigger for us today. That was used so commonly through this time period. I'll just highlight that. That's not a standout quote. Here's a quote we got from a patient. She was actually a nurse, and that's why, but she mentioned this. And she was a black nurse who actually had private insurance. So she's kind of the exception to the rule. She went to Duke OB, and here's what she said. They looked at me at the check-in. I'm African American. They didn't even look at her insurance status. They just put her on that public ward. And there was still a public OB ward at that point. Open ward. This is the early 70s still. That's not supposed to be happening, but it's still happening. And then she said they figured out the error, that she was supposed to be on the private ward. So they put her in a private room. But she said that was actually worse because nobody came to see her. She said, maybe I saw somebody 3 times the whole 21 hours I was in labor. And she actually thought, she was kind of wish she had been back on the public ward. So can you see how these practices are still happening? So don't think of 1965 as this moment where a light switch just gets turned off or on. There are these, racism continues to be maintained. And again, I'm trying to illustrate that point of how structural racism continues to act. And I'm hoping to be thinking about how it continues to work today. We also have a story of trying to change things and trying to diversify our people within the hospital. And I think I want to close with that story because I think there's a separate story of how gradually people who are not white begin to join the staff, become doctors at Duke as well. The first medical students come here at just exactly the same time as hospital desegregation, 63, 65, and onward. I'm going to pick out, this is Delano Meriwether, who's the very first Black medical student at Duke, and Jean Spalding, who's the first woman Black medical student at Duke. I have not been able to interview Dr. Meriwether. I have interviewed Dr. Spalding because she's still around. She's very much and she's had a lot of leadership roles with Duke later on, psychiatrist. And I would really encourage, well, she has a really interesting story. So she came to Duke in 1968. And this is a time where there's a lot of activism going on the Duke undergraduate campus, on the main campus. There is the Black students in 69, 1 year after she got here, the Black students on the Duke campus took over the Allen Administrative Building. Made a number of demands, one of which was to improve pay for African-American custodial workers. So she was in that, she saw that happen. And what she said was that the medical school was a different world. There was just none of this activism going on. There's still attendings with Confederate bumper stickers driving around. And when she was in medical school, she said she wanted to study schizophrenia in Black people. She was basically talked out of it for medical racist reasons. That isn't this, but what's there to talk about? She becomes a medical student here and then a resident. And she has an oral history that I would really encourage you to read. I think one of the most striking passages I'll just draw out of that history is she describes the Myers ward. Remember I showed you a picture of that? The psychiatry ward, which by that point had become the ward for severely mentally ill people, okay? And that also, like people with schizophrenia, that was also, we don't have a picture of it, but third floor of the old hospital, not a very nice looking place. They had gates and locks and stuff going in. That's also the word where any African-American patient who needed hospitalization would be admitted. Obviously, African-Americans, there had to be African-Americans admitted there who didn't have schizophrenia, right? They're just put there. But there's like there's a racist belief, medical racist belief at this time that schizophrenia is particularly a problem of Black people in this time. So they rationalize it, and she's just appalled by it all. This is the first African-American faculty in medicine, Dr. Charles Johnson. And he is actually an Air Force pilot before he came to Duke. He did a residency at Lincoln, then an endocrine fellowship at Duke. And he did become the first Black physician who's allowed to see private patients. In 1970, he was offered a faculty appointment by Eugene Stead, by the chair of medicine, working with Eugene Stead, who was a very powerful figure within the department. Johnson passed away several years ago. His son is alive. He's an historian, and there are a lot of stories that he has to share. Oh, I think the first one I wanted to share was when the Department of Medicine asked him if he would consider coming to Duke to see patients, becoming the first Black faculty. Johnson replied, well, I've got to see if my patients will come to Duke. And he wrote every single one. And he said most of them came, but there were two who didn't. One of the two who didn't come to Duke was actually a patient who was the head of the NC Mutual, which still is in business at that time. His name was William Kennedy. And he said that one time he had come to Duke, to the private clinic, and basically been made to wait the entire day. The doctor never saw him, and he went up to the Mayo Clinic. So that's a story we think from the early 60s. So just kind of think about that process. He's writing his patients to see if they'll come to Duke. He did accept after the patients when, accepted. And he had a hard struggle. He faced a lot of social isolation. There were specialists who wouldn't talk to him, wouldn't see his patients. And this is the 70s, okay? And his patients, I mean, these are generally middle-class African Americans they are often the inheritors of the African American elite that I've talked about. There were ward clerks who just dropped charts right in front of him and give it to him. But he still succeeded. He builds up one of the biggest practices in the private diagnostic clinic, and he became a mentor. I think we should think of Johnson as somebody who created a refuge, a protective space for more African American doctors. That next generation would be more activist and push back harder. But Johnson's role is very important in just being a mentor to them, giving them stabilization and mentorship during this period. This is again, a comment of the medicine chair Eugene said about Johnson. He said, I wanted Charlie because he was the toughest. He had been a fighter pilot before medical school. You had to have somebody who would get knocked down from time to time and start working again. And just, I mean, that speaks volumes of what his life must have been like. We are, we look at our medical school class today, and thankfully we are a far more diverse group than we were in this time period. That didn't just happen, okay? It happened because of people first like Dr. Johnson, the people he mentored, who gradually hung in at Duke and rose in the ranks. Brenda Armstrong is one that we're especially proud of. She was in pediatrics, one of the first pediatric African-American faculty. And she eventually rose in the ranks, became director of admissions. And she was a much more outspoken kind of activist than Dr. Johnson had been, sort of a second generation, I describe her. But she very much revered Johnson as well. She actually, as an undergraduate, had been in that takeover of the Allen Building, just to give you a flavor of who she was. You didn't mess with her. Unfortunately, she passed away, I think about 3 or 4 years ago. An amazing quite a force of nature. I have her picture up in my office to glare at me when I think of doing something compromising. So we've shared a lot. That's really what I wanted to share. I hope I'm drawing out of a lot of material. I hope by sort of separating drawing some stories out of this, it'll give it some coherence. I'm sure you have a lot of very different kinds of thoughts about this. There's a lot of disturbing stuff here we can see, and we could just really focus on naming that. But I really also encourage you to think about how are people going to think about us in 50 years? What kind of invisible or not so obvious kinds of racism are we participating in? You may well have other questions, but I thank you for your attention. And open to questions now.
Let me, we'll start with questions in the room, and anyone on the internet, just put your name or question in the chat. Okay, go ahead.
So the question is really, can we sort of translate this into what can we do within the system today? And that's a really, really great question. And I'm going to sort of say 2 general things. The first is before we do anything, it really is important for us to listen and to become conscious of the place of how racism works within the place we live and people we serve. Doctors, we're not naturally into learning history, right? And a lot of history, maybe it's fun to learn, but does it apply? I think it really is. I'll go walk on a limb. I think we have a moral duty to learn something about the history of our community. And it's often not that hard to learn. There's lots of opportunities in Durham to learn that. There's some really, Polly Murray, the Durham History Center, the Polly Murray Center have lots of, Stagville have lots of ways to learn about that. Learning and listening is really important. Learning to see what's going on around you. And I think my eyes were just kind of open by some of my historical work, just seeing how this stuff still plays out today. So in pediatrics, I work in two different clinics, one in South Durham, close to the big mall, and another one that's in North Durham. And although the physical plants actually look somewhat alike, the patients are very different. And the main kind of discrimination, I think we all say that we're providing equal care, and I think on one level we are. The fact that the North Durham Clinic, which serves a much less privileged group of patients, is mainly a teaching clinic, there's real harm in that. And we sort of learn just to go past, go say, well, more doctors seeing the patient, that's all the better. Those patients are there a long time, and especially, residents are just not there as consistently. And there are costs of not having that consistent relationship with a doctor. How we respond to that, I think there are ways to respond to that, but I feel like that's something I've become very conscious of, the lack of continuity of people who don't have private insurance. That often happens around here. As an example to me, that I've become more aware of. And then I think as you develop that awareness of what happens in the space you work, I think that helps you to decide what then to do. What kind of, and become conscious of maybe the little ways you're giving in. When that patient's saying, I don't want to see the resident, and and the family is white, and this happens in pediatrics a lot. Say, no, you start, don't give in. There's big structural things, but I think just your question was more at the individual level. What can you do?
But I think I'm going to say what Andrew's going to say. I would say just until 3 years ago in our department, the resident clinic was Medicaid patients, and everyone else went to the attendings. And that was having the exact same effect. And then thanks to our residency directors, that thing got completely changed. And now Medicaid patients go to the faculty. So, but it did take someone to think that, hey, maybe this isn't right. Because a lot of times you think what exists is fine, you know what I mean? Without thinking about it. Andrew, go ahead.
Yeah, that actually is what I was going to point out. You knew where I was going with that, because it was perpetuated. We didn't stop in the 70s or 80s. It was, what is this, 2024? So 2017 or 18 is when we made that change in resident clinic, so that there is no question when scheduling happens as to what kind of payment or insurance the scheduling is done independent of that. I don't know how much that's consistent across Duke or in other institutions. And in fact, what Dr. Eckstein and I were just talking about is when we interview fellows, we hear from residents from other institutions where that's still true. And so this is going on around the country.
Although,
we took care of it.
In retrospect, you'd say, of course we did that, but yet it took someone to notice it, right?
Yeah, right. So exactly. And the other thing, that we've been trying to work on is looking at our own practice disparities, to look at health disparities within Duke Neurology. And just for the department, this is data that we'll be presenting soon. We've collected this data to look at each of our divisions to ensure that we're not perpetuating disparities of care by race within our own practice. And what we did is we built an online calculator so that you could put in your data and it'll tell you we're practicing differently based on these groups. And you could use the calculator for race or gender or whatever you want to look at, so that anybody could track their own disparities. As sort of an objective way of measuring this.
That's terrific. I'm really terrific. I'm so glad to hear that. I think a lot of this is racism, the structures and subjects of racism sort of surround us like water surrounds a fish in a bowl, and just be able to see what's there, to name it. It really is an important step.
Why don't you take one last question? I think it's a good one. Oh, they were saying
compared to UNC.
Yeah, exactly. And I agree. That was going to be my next question. The influence in Medicare and Medicaid, because that happened at the exact same time. You said the hospitals started changing their inpatient policies, but that's another message. What about UNC?
Gosh, I'm not going to say anything good about UNC. No, no, I wish I knew more about it. I do have a counterpart historian at UNC. His focus mainly on the story of African-American medical students within the system. He's not taken a deep dive into patient treatment. I'm afraid I just don't know that much. It's a really different situation in the sense that the state provides direct money. So that's sort of another source of income. That helped them some, and also a tendency to draw more from rural areas. I wish I knew more about that. But I'm sure I bet a lot of the basic narrative is still to be pretty parallel.
All right, well, look, great. What a great talk. And thank you, Andrew.
Thank you again.